Hello everyone. This is Dental Digest with the Study Boards. I'm Dr. Trehan and today we are focusing on Glandular Odontogenic Cyst, that is GOC. Very uncommon but clinically important. Now to understand it better, let's take a quick look at what we will be covering in this session. To understand the Glandular Odontogenic Cyst comprehensively, we will go through 8 sections, starting with origin and etiology, then pathogenesis, followed by its clinical and radiographical features. Then we will look at the histopathology, then some possible complications, recommended treatment plan, and finally the differential diagnosis. Let's start by looking at origin and etiology of glandular odontogenic cysts. These cysts have a developmental etiology, meaning they arise from remnants of the dental lamina, specifically from the rests of seres or epithelial rests of mollusses. Now remember, these epithelial remnants normally participate in the tooth development, but under rare conditions, they can give rise to pathological cystic lesions like the GOC. Historically, these cysts were first referred to as cysto-odontogenic cysts because of their gland-like histological appearance, which we will see later in the session. Eventually, as more was understood about the odontogenic origin, they were reclassified and given the name glandular odontogenic cyst. And here is something important to note. GOCs are extremely rare. You can think of it making up less than 0.2% of all odontogenic cysts. But despite that rarity, their locally aggressive behavior and high recurrence potential make them clinically significant. Alright, let's talk about how a glandular odontogenic cyst actually develops. It all starts when the odontogenic epithelium, like the rests of seres, begins to proliferate abnormally. Basically, the cells start dividing and behaving in a way they normally should not. Now, as these cells keep on multiplying, parts of that epithelium begins to break down, and that's when small cystic spaces start to form. And these spaces look gland-like, and inside them you will often find goblet cells or mucin producing epithelium, and that's what gives this cyst its classic glandular appearance. Now if we look it under the microscope and test it for cytokeratin expression, it can actually show you a pattern which is very similar to salivary gland tissue. So it is imitating that kind of differentiation. And over time, if this process just keeps on going unchecked, the cyst can start to expand aggressively and even it can perforate the cortical plate in some cases. That's exactly why timely diagnosis and close follow-up becomes so important in GOC. Let's look into the clinical features of a glandular odontogenic cyst. Location-wise, it's most commonly found in the anterior mandible, although occasionally it can appear in the maxilla as well. Now it tends to affect adults in their 40s or 50s with slight male predilection. Now clinically, it's a slow-growing, painless swelling, which means it's often discovered by chance on a routine radiograph. And as it enlarges, you might notice tooth mobility or even displacement, and sometimes visible expansion of the alveolar bone can also be noticed. And if the cyst continues to grow and presses on the nearby nerves, the patient may even report of pain or altered sensation. Alright, now let's look at how a glandular odontogenic cyst appears radiographically. So you will see a well-defined radiolucency which can either be unilocular or multilocular, and it often has those scalloped borders that immediately will catch your eye. Now one very interesting feature, especially in the mandible, is that it can cross the midline. Not many jaw lesions actually do that, so it's a helpful diagnostic clue. Now as the cyst expands, it may displace or resorb adjacent roots, and those changes are usually quite clear on a panoramic radiograph. But remember, its radiographical appearance can easily mimic other aggressive jaw lesions like OKC, ameloblastoma, or even a central mucoepidermoid carcinoma. And that's why histopathological confirmation is absolutely essential before finalizing the diagnosis. Now let's see how a glandular odontogenic cyst looks like under the microscope. Cyst is lined by non-keratinized stratified squamous epithelium, so several cell layers thick but without a surface layer of keratin. Now within this lining, there are few hallmark features to look at. First are the hobnail cells. These are small cuboidal or columnar shaped cells that stick out into the cystic space, giving the surface that slightly bumpy or uneven appearance. Next, you will notice mucus goblet cells and tiny duct-like spaces. These are responsible for mucus production and gives the lining its classic gland-like look. Sometimes you will also find thicker plaque-like areas of epithelium and occasionally even bits of ciliated respiratory type cells. Now, when these features, especially the goblet cells and duct-like spaces, are seen together, they strongly indicate a GOC. And one important clinical point, if the cyst is multilocular or shows numerous plaque-like thickenings, it usually behaves as more aggressively and carries a higher risk of recurrence. Let's talk about why the glandular odontogenic cyst is considered clinically important. It's not just rare, it's also locally aggressive and has a pretty high recurrence rate, around 20 to 30%. That's why long-term follow-up is absolutely essential after treatment. Now, as the cyst grows, it can start to erode through the cortical plate, as we discussed earlier, resorb even the nearby roots, and even push the neighboring teeth out of the alignment. And if it keeps on expanding unchecked, you can end up with significant jaw deformity, which affects not only the function but facial aesthetics as well. So the takeaway here is clear. Early intervention and regular post-operative monitoring is critical. So how do we treat glandular odontogenic cyst? We usually start with enucleation and curettage, basically removing the cystic lining and lightly scraping the bone around it. It's a conservative approach that works really well, and in most cases it also helps preserve the healthy tissue. But if the cyst is too large, or it has made the bone paper thin, or it comes back, then we move into a marginal or segmental resection to clear it out completely. Because these cysts recur in roughly 1 out of 4 patients. So long-term follow-up, as we discussed earlier, with regular imaging is non-negotiable. And if the surgery leaves a large gap in the jaw, we can rebuild it with the bone grafts or implants to restore both appearance and the function of the patient. Now let's look at the differential diagnosis of GOC, because on the radiograph, several jaw lesions can look pretty much similar. That's why histology becomes absolutely critical to tell them apart. An odontogenic keratocyst, OKC, can show a multilocular radiolucency, but its lining is corrugated and parakeratinized, not gland-like GOC. A dentigerous cyst, it normally wraps around the crown of an unerupted tooth and does not have mucous cells. Then there is the botroid odontogenic cyst, a multilocular lateral periodontal variant. Again, no goblet cells and no epithelial plaques. The GOC can also mimic a central mucoepidermoid carcinoma, but remember, that lesion contains malignant mucus and epidermoid cells. Then a meloblastoma, it may look similar radiographically, but it's multilocular, locally aggressive. But under the microscope, you will see palisaded columnar cells and stellate reticulum-like areas, not glandular structures. Radicular cysts, being inflammatory, usually appear as unilocular periapical radiolucency without any glandular epithelium. And finally, expansile bone lesions like central giant cell granuloma or even aneurysmal bone cyst, which may look very similar on imaging, but microscopically they show giant cells or blood-filled spaces respectively. All right, let's quickly recap what we have just discussed about glandular odontogenic cyst. First, we talked about where it comes from. It's a developmental cyst that originates from odontogenic epithelium, specifically the rests of seres. Then we moved into the clinical features, remember? It usually appears in the anterior mandible, middle-aged individuals, then it's slow-growing, painless swelling, and it can sometimes even cross the midline. Then we talked about histopathology, and here just keep 3 things in mind: hobnail cells, mucus or goblet cells, and duct-like spaces. That's the classic triad that you're looking at when you're trying to identify GOC. After that, we talked about the management. Start with enucleation and curettage. And if it's large or if it is recurring again and again, you might actually need resection. Then always ensure a long-term follow-up. And finally, we discussed the differential diagnosis. We compared it with lesions like OKC, dentigerous cyst, ameloblastoma, central mucoepidermoid carcinoma. And the key takeaway being histopathology is what confirms your diagnosis. Thank you so much for watching this video. If you liked it, please hit the like button and subscribe to the channel for more updates. Until then, keep working hard. I'll see you in the next one.